me?
Yeah, I have you okay. Can you hear us okay?
Yeah. I was just making sure. I tried my headphones,
Yeah,
but it didn't seem like my microphone was working when I had them on.
yeah. We could hear you. I'm not sure if you could hear
Oh,
us.
yeah, I wasn't able to hear you. I
Yeah,
can't figure out the Bluetooth with this
yeah,
computer.
it's tricky. Okay. Well, we got you. I just started the recording, so whenever
Okay. Was
everybody's
the
on, go ahead and start.
was that screen share working
Yep.
when I had it up? Okay. I'll
Yeah, it was good.
piggyback there.
I have a school drop off, so I'm going to throw you on record, but will you make sure to send me your slides since I can't
Yeah.
watch them? That would be awesome. Thank
Yep,
you.
absolutely.
Yeah, just later is fine. You don't have to do it now.
Sounds good.
All right.
All right. Looks like we got everybody here. What's up, guys?
Morning. How was your trip?
It was good.
Good.
Got in at like 9:30 last night. Just hung out, said hi to them, and went to bed around 11. A little tired, but wasn't too bad. Pretty straight drive. Although I will say that having Morgan drive, I was working on this presentation for like the first 4.5 hours. And then I
Yeah.
looked up from my computer and I was like, dang, I should have been scared for a little bit longer. She was like, it was all good till the last hour and a half. And I'm like, that was as soon as I started looking up. All right. So this lecture, relatively dry. It's a lot of just reviewing and kind of going through all the medications. And then the second or kind of last third of it, we'll go through some of the doping. So we'll talk about like the substances that are banned, the ones that are banned in competition, ones that are banned out of competition, and then we'll talk about what the guidelines are for screening, et cetera. Let me see if I can get this slide to change. There we go. So again, we'll identify common medications used in sports med. A lot of that is going to be strictly review for everybody. Very simple stuff. And then we'll talk about kind of what their indications are, contraindications, and then the general safety profile for each of them. Discuss pharmacology's role in optimizing athlete performance. And then again, we'll identify common PEDs and then their impact on performance and their adverse side effects. And then we'll go through the WADA guidelines and anti-doping screening, and then some ethical implications of doping. One little caveat that I threw on the bottom of this is all pretty much from that sports medicine third edition Finoff and Harris book. There are other chapters like infectious disease, cardiology, pulmonology, et cetera, that go through specific conditions and medications to treat those conditions. This is more just a general review of the meds, and then they're basically the whole pharmacology behind them, the mechanisms of action and indications and contraindications. All right, fellas, let's dive in. Hang with me here. So we'll start with analgesics. The three that are most often prescribed would be acetaminophen, opioids, and tramadol. For acetaminophen, the exact mechanism's unclear. Thought to elevate the pain threshold, and then may also inhibit nitric oxide pathway, and then also um, through a variety of neurotransmitter receptors, including N-methyl D-aspartate and substance P, fever reduction by inhibition of endogenous prostaglandins in the central nervous system, and then little to no anti-inflammatory effects. You'll notice too, as I go through here, I've highlighted all of the points in each slide that tend to be the most relevant. Also, the points that I think are going to be things that we may not have remembered and likely are going to be the most, I guess, relevant for boards too. Indications for acetaminophen. So it's the first line agent for mild to moderate osteoarthritis. And then there's kind of lists of the colleges or academies that have approved this for that treatment. And then it's also the first line agent for medically complex patients. So for mild to moderate MSK pain in those over 50, those with cardiac conditions or other risk factors, and then those with underlying renal conditions as well. I think everybody is generally aware that it has a better GI safety profile than NSAIDs do. Then again, using it for temporary relief for minor aches and pains, such as common cold, headache, toothache, muscular aches, backache, arthritis, menstrual cramps, and then reduction of fever. Contraindications. So chronic alcoholics might be at risk for liver disease, but a lot of conflicting evidence. And then it's also reportedly safe in chronic stable liver disease, but there's some conflicting evidence there as well. Overdose can happen in conjunction when taking anticonvulsants and might increase your risk of liver injury. You might also have a higher risk with excessive caffeine intake. The recommended maximum daily dose is 3,000 milligrams per day with a narrow safety window. I would guess that all the fellows are pretty aware of that because Dr. Cupp tends to go through that on a daily basis. Maximum daily recommended dose in Europe, however, is a little bit higher at 4,000. With opioids, so most common opioids that we see prescribed are going to be codeine, Demerol, hydrocodone, morphine, oxycodone, and fentanyl. Mechanism of action is going to bind opioid receptors, primarily the mu, kappa, and delta receptors, and it'll have central nervous system and peripheral effects. Codeine conversion into morphine in the liver is dependent on cytochrome P450. We're all generally aware of that cytochrome P450. I think we've heard it a million times from the time we started medical school until now. Propoxyphene adds little anesthesia to acetaminophen, but it's not available in the US, just available in Australia. Indications would be moderate to severe pain. You might use codeine for cough, and then there's loperamide for diarrhea. I frequently forget loperamide's even involved in the opioid class. Contraindications, so if they have any hypersensitivity or allergy to the medication, if there's any concern regarding combination with other medications such as acetaminophen, you can have a higher risk for toxicity to the liver. Any history of dependency or addiction. If they're an athlete and we want to treat their pain, but they might be going through drug testing, that's also a reason why we might want to avoid this. And then I have the relative potencies listed here. Tramadol, so it's a synthetic analog of codeine, has a low affinity for opioid receptors, but its primary metabolite actually has a high affinity. It's only partially inhibited by naloxone. Norepinephrine and serotonin reuptake inhibition is also part of the mechanism of action. And this medication also might come in combination with acetaminophen. Indications for tramadol would be moderate to severe pain as well. And then one big thing to remember is that taking tramadol and an SSRI or an SNRI can actually predispose to serotonin syndrome. For antibiotics, so they really only go through penicillin and fluoroquinolones. I was like, as I'm reviewing, like there's a lot of other classes of antibiotics that we often prescribe, and so I was curious why they weren't listed. And if you go to the chapter for infectious disease, they do have these listed, but they're all kind of mentioned with treatment of specific conditions. And so I left them off of this to kind of review the full pharmacology of the other antibiotics. So we'll focus primarily on penicillin and fluoroquinolones. So mechanism of action for penicillin is to weaken the bacterial cell wall by inhibiting formation of peptidoglycan crosslinks. There's little research on penicillin with athletic performance, often overprescribed for elite athletes for non-bacterial conditions. And then many athletes will fear adverse side effects from this medication, primarily the GI side effects. With fluoroquinolones, the mechanism of action is to inhibit bacterial enzymes responsible for DNA replication and transcription. Contraindications would be known hypersensitivity. Otherwise, any central nervous system conditions such as epilepsy, history of stroke, or meningitis. If they have a prolonged QT syndrome, and then in children, there's risk of growth plate injury and tendon rupture, which I think we're all relatively aware of. Other risks, this might cause tendinopathy or even spontaneous tendon rupture, particularly in the age group over 50 and any patients that are taking corticosteroids, whether that's acutely or chronic. Um, Other medications we often see for diabetes would be insulin, thiazolidinediones, sulfonylureas, lipidinides, and then biguanides. So for insulin, it's going to inhibit intracellular lipase, and that hydrolyzes triglycerides to release fatty acids. Um, it also facilitates entry of glucose into adipocytes and the synthesis of glycerol in those cells. It's delivered through sub-Q injection. One thing to consider would be pre-exercise injection. You want to avoid any injection into the primary muscle that's being exercised. One example they had mentioned was injecting into the thigh for a cyclist, because that's a common spot that people might inject insulin. There could be an increased uptake, and it might cause hypoglycemia. Multiple formulations with different onsets and durations. And then these are kind of the different formulations that you might see of insulin, when their onset is, when they peak, and their duration of action. So indications for insulin use would be patients with type 1 or insulin-dependent diabetes. Otherwise, anybody that is poorly controlled with type 2 diabetes, with oral hypoglycemics, diet, and exercise alone. Contraindications would be hepatic disease, renal disease, or renal impairment. It can cause and also should not be used in the setting of hypoglycemia, as well as hypokalemia, which we might remember from our ER or ICU or internal medicine rotations back in residency. Also, any history of insulin hypersensitivity or allergy. Risks, so low blood sugar, we might see weight gain as well. Bronchospasm with inhaled insulin, I don't think I've ever seen that prescribed personally. Any sustained nausea or vomiting, which might be a sign of an insulin allergy, and then any history of skin rash or lesions at the injection site. That's not actually a full contraindication in this case, but often a side effect that we can see with this medication. One thing to keep in mind is that insulin can actually be used to enhance performance, given it has anabolic effects similar to IGF-1 when it's taken with glucose. So thiazolidinediones, the mechanism is not entirely clear. It lowers insulin resistance. The common medications we might see are pioglitazone, rosiglitazone, and they might also have impacts on lipids, such as pioglitazone reducing triglycerides and increasing HDL. Rosiglitazone would increase HDL and slightly lower LDLs, generally not used as a first-line agent for diabetes treatment. So risks and side effects, so upper respiratory infections and sinusitis, headaches, anemia. One that we might often see and is a little more relevant is fluid retention, which may lead to congestive heart failure. And so we want to try to avoid these medications in any history with congestive heart failure, specifically with reduced ejection fraction. That might also cause weight gain, muscle pain. There's an increased risk of fracture in women, and then a possible risk of seeing liver damage. Sulfonylureas, so it increases the amount of insulin produced by the pancreas. Sometimes we might see it combined with metformin, also decreases the amount of glucose produced in the liver. They're long-acting. Dose adjustment might be necessary to prevent hypoglycemia, especially if anyone's taking a sulfonylurea with competition or during training. Often, the most common medications we might see are glipizide, glyburide, and glimepiride. Risks and side effects. So one would be a sulfa allergy. They're also teratogenic, so we want to avoid these medications if pregnant or trying to become pregnant. They're unsafe if there's any history of liver or kidney problems, as they're metabolized by the liver and excreted by the kidneys. Consuming alcohol while taking sulfonylureas will increase the risk of low blood sugar. Hyperinsulinemia, again, because it's stimulating the pancreas to secrete more insulin, might lead to increased cardiovascular disease, and then also may cause weight gain. Meglitinides, so they increase the amount of insulin produced by the pancreas, similar to a sulfonylurea. However, these are faster acting, not longer acting, and they have a shorter duration. Two common medications that honestly I never see prescribed, but would be repaglinide and nitaglinide. Risks and side effects, so they may not be safe in pregnancy, and then they have similar side effects to sulfonylureas and may not be safe in liver or renal disease. I think honestly, they say they may not be safe in these situations because we don't see them prescribed very often. Bigonides, so this is going to be our metformin. Mechanism is not completely well understood, but it thought to decrease glucose production in the liver, increase glucose absorption in muscle, and decrease insulin resistance. I think the biggest effect it has is decreasing insulin resistance, and that kind of gives rise to why it's used not only in diabetes, but in other situations, which I'll go through here in a second. Metformin is going to be the most commonly used anti-diabetic drug in the world, considered first-line agent in type 2 or non-insulin dependent diabetes when diet and exercise alone are not effective. And this medication is not associated with hypoglycemia. Risks and side effects, so nausea, loss of appetite, diarrhea, increased abdominal gas, metallic taste, rarely lactic acidosis during exercise. There's a higher likelihood if there's any history of liver or kidney problems, and this can be associated with dehydration as well. And then metformin will be contraindicated in renal impairment patients, so anyone with creatinine over 1.4. Other common indications for metformin, PCOS, non-alcoholic fatty liver disease, and premature puberty. I'll start going through the antihypertensives, again, going through the list of the most common medications that we see. So calcium channel blockers, ACE inhibitors, ARBs, diuretics, and beta blockers. Of note, the JNC8 recommends initial use of thiazide diuretic, CCB, ACE inhibitor, ARB, or an ARB in the general non-Black population. And then in the general Black population would be use of thiazide diuretic or a calcium channel blocker. So for calcium channel blockers, mechanism of action, they block L-type calcium channels, and this relaxes vascular smooth muscle, which then dilates the blood vessels and reduces peripheral vascular resistance. The dihydropyridines, such as amlodipine, are going to be stronger at doing this than the non-dihydropyridines. For those non-dihydropyridines like diltiazem and verapamil, we often see that a little more with arrhythmias or tachycardias. And so they decrease myocardial contractility, slow the heart rate, and they decrease cardiac oxygen requirements. Indications would be hypertension, angina, and abnormal cardiac rhythms. Contraindications, so verapamil and diltiazem, the non-dihydropyridines reduce heart rate and strength of contraction, and so they might not be the best choice for patients with CHF or in athletes. Amlodipine or dihydropyridine has little effect on the heart rate, so it's not a great choice for treating anyone with arrhythmias, but it would be the ideal choice if we're choosing a calcium channel blocker in athletes. Risks or side effects, so verapamil and diltiazem decrease elimination of many drugs by the liver. Grapefruit juice might elevate concentrations of some CCBs. Common side effects would be constipation, nausea, headache, rash, hypotension, and the one that I think we're all relatively familiar with is peripheral edema. ACE inhibitors, they inhibit ACE. I think we all can kind of figure that one out. They also decrease production of angiotensin II, which then dilates blood vessels and lowers blood pressure. Angiotensin II is going to be a potent vasoconstrictor, so when we decrease its production, that leads to dilation of the blood vessels. Indications for ACE inhibitors would be elevated blood pressure, hypertension, congestive heart failure, can be beneficial with stroke prevention. They improve post-myocardial infarction survival. So this is another kind of like question that you might see that I think we're all somewhat familiar with, is that when should certain medications be used? And then what does the research show, right? So for ACE inhibitors, they're improving that post-myocardial infarction survival. And then these medications can also be used in renal impairment, but not renal failure. Contraindications, they're not to be used in pregnant individuals because of the neural tube defects, anyone with renal artery stenosis, and any history of hypersensitivity to the medication. Risks and side effects, so cough, they can cause hyperkalemia, can lead to hypotension and dizziness, headache, weakness, rash, metallic taste, and they might also increase lithium levels if patients are concomitantly taking lithium. ARBs, they're going to block the action of angiotensin 2, which again is a potent blood vessel constrictor. That's going to decrease blood pressure and also decrease cardiac work. Indications would be hypertension, prevention of kidney failure in those with hypertension or diabetes. They might prevent recurrence of AFib, and often these medications are used if ACE inhibitors are not tolerated. Most frequently, when they have a cough as a side effect of an ACE inhibitor, we typically just want to switch to an ARB. Contraindications, again, not to be used during pregnancy, not to be used in renal artery stenosis, any history of hypersensitivity to the medication, and we do not want to use these in combination with ACE inhibitors. Risks and side effects, very similar to the ACE inhibitors, so cough, hyperkalemia, hypotension, dizziness, headache, rash, diarrhea, and metallic taste. Diuretics, the mechanism of action is to increase sodium chloride excretion in urine. Hydrochlorothiazide is acting at the distal tubule, and furosemide or Lasix is acting at the loop segment. Indications, hypertension, often it is an initial choice in the general population, usually hydrochlorothiazide, not generally starting with Lasix as initial treatment, and then also treatment for fluid retention. Contraindications, pregnancy. The big one here is that it's prohibited to be used in athletes because it can act as a masking agent for performance-enhancing drugs during urine tests. So that's a big thing, and we'll kind of go through that again towards the end here. Risks and side effects, so volume depletion, it might predispose athletes to dehydration and heat-related illness. Potassium imbalance with both hydrochlorothiazide and loop diuretics would lead to hypokalemia, decreased athletic performance, and might also contribute to cardiac events because of dehydration. So beta blockers, mechanisms of action, can be slowing the heart rate by decreasing the response to sympathetic input. It also decreases contraction of smooth muscle in the peripheral arteries and airways, slows resting heart rate, decreases the cardiac response to exercise, and may have an adverse effect on cardiovascular training, particularly those that are endurance trainers. Indications for hypertension, tachycardia or rate control with tachycardia, angina, and it's the post-myocardial infarction drug of choice. Contraindications, this might increase asthma symptoms because, again, as we kind of go up, decreases contraction of smooth muscle in the peripheral arteries and airways. Oh, sorry. And then another contraindication, again, it's a prohibited substance in participation in several sports, such as shooting, archery, powerboating, because of the anti-anxiety effects. So that might be something that we could see on CAQ, is when beta blockers are absolutely prohibited, and it's in those sports that kind of require those fine movements. Risks and side effects would be depression, fatigue, male impotence, increased wheezing, nightmares, and then it can also impair athlete performance. So getting into asthma medications, medications we often see prescribed are anti-inflammatories or glucocorticoids, Kellen derivatives, usually used in children. We honestly probably don't see this very often, but occasionally we will. So like our cromolyn, we might see used in some children. Anti-leukotrienes, and then bronchodilators. So glucocorticoids, inhaled glucocorticoids specifically will upregulate gene expression of anti-inflammatory proteins and downregulate gene expression of the pro-inflammatory proteins. Its indications would be the treatment of choice for chronic asthma, and then a second line agent after rescue inhaler for asthma. Contraindications are hypersensitivity to glucocorticoids and should not be used as a rescue agent. Takes 1 to 3 weeks for the full effect. Risks or side effects. Chronic use can lead to osteopenia and osteoporosis. We might see thrush, especially in the older population, and then hoarseness. So the Kellen derivatives we often see used in children with mild symptoms. It's derived from the plant Amivisnaga. Bronchodilators will inhibit histamine release from mast cells. Again, cromolyn is the one that I've seen most often. It's indicated in those greater than 2 years of age, and then nedochromyl sodium is indicated in those greater than 6 years old. Anti-leukotrienes. So the mechanism of action here is to block the leukotriene-induced bronchostriction. Also can block leukotriene synthesis with xyluton, or block the leukotriene receptors such as montelukast or singulair. It decreases inflammation and has a very rapid onset. Indications might be used for allergy or asthma symptoms. Any contraindications would be hypersensitivity to the medication. And then these phenylketonuria should not be used because they contain phenylalanine, which you see in aspartame. And that was something I was not aware of. So we don't want to use this medication if they're consuming any aspartame, which is commonly consumed. Risks or side effects. Xyluton not approved for children because it requires hepatic testing. And then any runny nose, headache, fever, stomach pain, or diarrhea. Those are the most common side effects of this medication. So with bronchodilators, they relax bronchial smooth muscle and decrease mucus secretion. Indications. So inhaled short-acting beta agonists, it's the main rescue medication or first-line treatment for asthma. Oral forms are not approved by the NCAA or WADA. Long-acting beta agonists, such as salmeterol, have a 12-hour duration and should not be used as a rescue or acute medication. Also associated with increased risk of death associated with asthma. Risks or side effects. So oral medication, clenbuterol, is banned due to its anabolic effects, but it's not actually in any ingredients in FDA-approved drugs in the US. So getting into NSAIDs and COX-2 inhibitors. So the mechanism of action is that it blocks COX and COX-1 and COX-2, particularly COX-2, and that'll reduce prostaglandins. Indications would be for pain, fever, inflammation, or arthritis. Contraindications, again, kind of noticing a theme, any hypersensitivity to this medication in the past. And then one big thing to kind of remember, you might recall from our family medicine board studying, is that children and adolescents recovering from a viral illness such as chickenpox or influenza should avoid aspirin due to the risk for Ray's syndrome. You also want to avoid aspirin or conventional NSAIDs if known or high risk of GI ulcers, especially those with GI ulcer, active bleeding, or history of GI bleed. Risks and side effects. So renal disease, any history of GI bleeding, we definitely want to avoid, but can also cause when taken at high doses for longer periods of time. Other side effects are headache, rash, nausea, and vomiting. There's GI protective capacity for COX-2 agents, which I wasn't aware of. However, this is mitigated by any concomitant aspirin use. Animal studies suggest COX-2 may affect ligament strength, but there's no clinical demonstrated difference in human muscle strength. There's no evidence to suggest individual superiority for pain, aka comparing ibuprofen to naproxen to celecoxib to meloxicam. There might just be individual patient preferences. There's going to be dose-dependent side effects. Lower doses might produce or provide an analgesic effect, and higher doses have an anti-inflammatory effect. Conventional NSAIDs block COX-1 and COX-2, used for pain and inflammation. They block prostaglandins in the GI tract, and then renal dysfunction, and there's platelet inhibition, which is why it can lead to increased risk of bleeding. COX-2 specific inhibitors, such as celecoxib, there's actually decreased GI toxicity. And then they have increased cardiovascular risks as, I guess, a risk or adverse effect with celecoxib. And I saw an older study showing that. And then there's actually some newer studies, particularly through like New England Journal of Medicine and the AHA, that showed that there's actually not an increased cardiovascular risk when using celecoxib compared to ibuprofen, naproxen, and other often prescribed NSAIDs. And then the COX-2 selective inhibitors, such as meloxicam, have decreased GI side effects, which I think a lot of us are aware of because we often prescribe it to patients that don't tolerate other NSAIDs. It can be taken once a day. It's longer acting. It has unknown cardiovascular risks. And then etodolac has a higher COX-2 selectivity. So viscosupplementation. A lot of this is going to be important, particularly for the CAQ. I know I saw a couple of questions on this, primarily with the mechanism of action. But hyaluronic acid is an unbranched, high molecular weight polysaccharide distributed throughout the body, especially as a major component of synovial fluid and of cartilage. The primary role of HA in synovial fluid and cartilage is to maintain the viscoelastic structural and functional characteristics of the articular matrix, which is a mouthful, but again, important to know. Mechanism of action, the rheological mechanism of action. I had to Google what rheology meant, so I threw it up here if anybody else didn't know what this meant. It's the science dealing with deformation and flow of matter. So the rheological mechanisms are immediate restoration of synovial fluid viscosity and elasticity, maintenance of increased rheological properties for 3 to 7 days after injection, has an anti-nociceptive effect, and then it acts as a mechanical sponge or a sieve in the way that it assists with removal from the joint of immune complexes and anti-inflammatory cells. The biological mechanisms of action, so it has an anti-inflammatory effect, has an effect on immune cells, can also restore hyaluronate synthesis due to positive feedback for endogenous hyaluronate synthesis. Effects on cartilage, it increases biosynthesis and decreases degradation. Effect on the chondrocytes would be that it decreases apoptosis, and then proliferation. Also has an antioxidant effect. Indications, so there's a lot of different brands of viscosupplementation. Often what we'll see is Synvisc, Hyalgan, Orthovisc, Euflexa, etc. Differences are based on molecular weight and how they're produced. So Euflexa is bacterially derived, Orthovisc is synthetic, and then all of the rest are derived from rooster combs. There have been strength gains demonstrated after viscosupplementation due to pain relief. It's supported by a Cochrane database for knee osteoarthritis, also supported by the AMSSM position statement on use of viscosupplements for treatment of knee osteoarthritis. Contraindications, any history of allergy, and then any allergy to poultry or eggs, except for those that are non-avian derived, such as Euflexa and Orthovisc, which I also was not aware of. Risks and side effects, so any local or systemic reaction previously. Injection site pain, not a contraindication. We see this very frequently, but can definitely be a side effect, can cause infection, and then also risk of bleeding. So corticosteroids, various routes to use corticosteroids, oral, inhaled, injected, topically, and then through iontophoresis or phonophoresis. Again, that's going to be electrical versus ultrasound. limited efficacy studies, both for acute and chronic conditions. Injection complications. These, I know I saw this on our ITE. Fat pad atrophy and hypopigmentation are going to be the most common complications. Injection into tendon not recommended due to risk of tendon rupture, but paratendon injections are probably safe. Shout out to Justin for injecting my ECU tendon sheath yesterday. There's also a theoretical risk of diminished resistance to COVID-19. Yeah, I threw it on this slide. So I remember one question specifically on which injected steroid to use to avoid, I think it was talking about fat pad atrophy or hypopigmentation. And that's largely dependent on the solubility of the medication. And this doesn't, so this is just a chart they had in our book. Then I went to Google and I was trying to find a better chart, but I could not. But betamethasone actually has the thing is the lowest solubility, and so it has the lowest risk for fat pad atrophy and hypopigmentation. But again, these are often, or the most common corticosteroids we might see, so triamcinolone, methylprednisolone. Beginning in 2021, corticosteroids are prohibited in competition by the WADA if administered orally, rectally, or by intramuscular or IV injection. They are permitted in and out of competition when administered by inhalation, intranasal, ophthalmic, perianal, dermal, or injections into the bursa, joints, or the epidural space. General athletic concern, one would be photosensitivity reactions. So diuretics, antipsychotics, older generation antidepressants, hypoglycemics, cardiovascular drugs and antimalarials, NSAIDs, antimicrobials, and antihistamines, and estrogen and progesterone. So the most photoactive NSAIDs are 2-aryl-propionic acid derivatives such as ibuprofen, naproxen. Other NSAIDs include diclofenac, piroxicam, indomethacin, and then I've never seen Sulindac, and other COX-2 specific inhibitors. Antibiotics, again, this is just kind of going through some other antibiotics we might see, would include tetracyclines, so doxycycline, minocycline, but there's a lower incidence of that photosensitivity reaction with those medications. Fluoroquinolones and sulfamethoxazole. In female athletes, combined oral contraceptive use and topical medicines such as retinoid creams for acne may be used. So now we'll get into performance enhancing drugs or agents, and then we'll kind of go through the doping guidelines and screening. I'm going to take a sip of water too. Any questions to this point? Sounds good. We'll keep on chugging along. So performance enhancing drugs. So just a brief history on doping, particularly. So initially with Chinese Emperor Shen Nung depicted with ephedra, and then ancient Olympians drank herbal teas and ate mushrooms. In the late 1800s, there were cycling deaths due to overdose with doping or performance enhancing drugs. And then there has been a gradual process in fighting against performance enhancing drugs. The first list banned substances by the IOC in 1967. Other medications added to the list, and then most recently, over the years, some medications have been added as masking agents, which again, like our diuretics, which we'll kind of go through here in a second. More on the history, the original use of the term doping was controversial, has a South African dialect. Then there's this Boers religious festivity infusion, the doop, and then Amsterdam canal workers would use the term doopin. In modern Olympics, amphetamines, later anabolic steroids, and then both had prior military applications. These medications, amphetamines and anabolic steroids. I don't know if everybody's like heard the story about the Nazis using amphetamines, which is kind of why they had so much energy and were able to keep plugging along. So 2 of 3 of these criteria meet the definition for doping. So use of substances or methods that artificially increment performance, substances or methods that are harmful to athletes, and substances or methods that are against the spirit of the games. As far as structure goes for performance enhancing drugs, doping, so kind of our anti-doping legislative bodies, the International Olympic Committee had its anti-doping resolution passed originally in 1962. The banned substance list was released in 1967, and the first testing started at Mexico Olympics in 1968. So we're all relatively aware of the World Anti-Doping Agency. This idea was developed after 1998 Tour de France. If you guys remember, like Lance Armstrong and his use of erythropoietin. So this is due to the difference between governments and International Cycling Federation. They wanted a general overseeing body. So that's why they started the World Anti-Doping Agency. Took over many aspects of the anti-doping movement after the IOC and after Sydney Olympics in 2000. WADA is now based in Montreal, Canada. And so WADA has the code, which is the document that provides the framework for anti-doping policies, rules, and regulations within sports organizations and among public authorities to harmonize anti-doping policies and ensure standards. Many other leagues and sports have their own anti-doping efforts, various international sports federations, and then most professional sports leagues like NFL, MLB, et cetera, have their own anti-doping bodies, and then the NCAA as well. Categories for performance enhancing agents is any substance without the approval by government, health agency, or human use. Substances prohibited at all times, which will go through each of these categories here. Prohibited methods in competition and out of competition, substances that are prohibited during or in competition, sport-specific prohibition, other agents, and nutritional supplements. So the substances that are prohibited at all times, both in competition and out of competition, are anabolic steroids, peptide hormones, growth factors, and related substances, beta-2 agonists, hormone antagonists and analogs, diuretics, and other masking agents. So anabolic steroids initially developed after World War II to treat emaciated prisoners of war. In 1954, Soviet athletes began using steroids, was used for strength gains, speed, endurance, and healing injury. And this was applicable to nearly all sports. Initially, control over anabolic steroids started in London in 1974, and it was added to the IOC banned list in 1975 prior to Montreal Olympiad. Anabolic steroids, so WADA list of 2021 includes endogenous anabolic steroids, so androstenediol, androstenedione, DHEA, and epitestosterone. There's also an exogenous list of anabolic steroids. I'm not necessarily going to read all these off, and you guys have to listen to me struggle to pronounce them, but this is the list. And again, these are all listed in that FinOff book, and then also on the WADA website, which I have a link to later in the slides. So risks with anabolic steroids are implicated in liver disease, also can see psychiatric effects such as mood swings and aggression, overall limited data despite decades of use and abuse. So peptide hormones, growth factors, and related substances. So often we might see erythropoiesis stimulating agents, EPO itself, and then there's other kind of erythropoiesis stimulating agents listed below. The risks that are associated are that it was actually implicated in cyclist death due to hyperviscosity and thrombosis. Most often, you might see this medication used in endurance athletes. Chorionic gonadotropin and luteinizing hormone in males, insulins, corticotropins, and then growth hormones and growth factors such as IGF, platelet-derived growth factor, vascular endothelial growth factor. So list of, again, going down our prohibited substances, beta-2 agonists. So there's only 4 inhaled beta-2 agonists. There's albuterol, formoterol, salmeterol, and vilanterol. They're permitted at all times. However, they're only permitted when doses are maintained under a very specific threshold, and those thresholds are listed below here. No other beta-2 agonist is allowed regardless of the route of administration. So hormone antagonists and analogs, there's aromatase inhibitors, selective estrogen receptor modulators like tamoxifen, anti-estrogen substances, and myostatin inhibitors. Diuretics, so Lasix and hydrochlorothiazide. Again, our risks include dehydration, electrolyte disturbances such as hypokalemia, and environmental illness, aka heat stroke or anything associated with heat illness or dehydration. And then masking agents, so diuretics, and then there's the plasma expanders such as glycerol and dextrose. Again, these can affect a urine drug screen, and so they're banned substances. Prohibited methods in competition and out of competition. So any enhancement of oxygen transfer. This includes blood doping, so it includes autologous, homologous, or heterologous blood or blood products, artificial enhancement of uptake, transport, and delivery of oxygen. So the perfluorochemicals, efaproxerol. Again, I'm sorry, I'm struggling to pronounce all of these. Any hemoglobin substitutes, and this does not include supplemental oxygen. That's probably an important one to remember, and one I probably should have highlighted here. You can also have chemical and physical manipulation, so tampering with samples, any IV infusions, except those for legitimate medical reasons. Caveats here, you can receive an IV infusion of less than 100 milliliters within a 12-hour period if the substance is not on the prohibited list. Then IV infusions over 100 milliliters within a 12-hour period are prohibited unless administered as part of a hospital treatment. And then there's sequential withdrawal, manipulation, and reinfusion of whole blood. Gene doping, so involves the transfer of nucleic acids or nucleic acid sequences, use of genetically modified cells, or use of agents that alter gene expression, such as peroxisome proliferator, which activates gamma receptor. So these are this is a list of substances that are prohibited in competition. So we have stimulants, narcotics, cannabinoids, and glucocorticoids. So stimulants initially developed in World War II for military use. In the 1940s was used for football, and 1950s used often in other sports. Amphetamines demonstrated perceived positive effects on self-confidence, mood, attention, aggression, and energy. OTC stimulants like phenylpropanolamine, ephedrine, and pseudoephedrine became substitutes for amphetamines in the 1970s. And then that phenylpropanolamine and ephedra containing substances were banned by the DEA in 2004. Other stimulants, modafinil, adrafinil, were first developed in France, but only modafinil is legal in the United States. Usually we see that for like daytime hypersomnolence or narcolepsy. Not picked up on urine tests for stimulants. Bupropion, caffeine, phenylephrine, phenylpropanolamine, piperdol, and synephrine are not considered prohibited. Adrenalines associated with local anesthetic injection are not prohibited. And then ephedrine, methylephedrine, pseudoephedrine are prohibited in competition. Narcotics, so prohibited medications include buprenorphine, morphine, hydromorphone, methadone, oxymorphone, fentanyl, oxycodone, and others. The one that's not prohibited in competition is codeine. Other substances prohibited in competition, cannabinoids. There are natural cannabinoids, cannabis, hashish, and marijuana. All natural and synthetic cannabinoids except cannabidiol are prohibited. Then there's synthetic version, such as delta-9 THC, and then cannabimemetics, such as spice. So this is sport-specific prohibition, alcohol. So any alcohol consumption or levels greater than 0.1 gram per liter, prohibited in archery, aeronautics, automobile, karate, motorcycling, powerboating, and bowling. Again, a lot of this is just memorization of what sports are prohibited with certain substances. With beta blockers, I think this might come up, and I think we saw it on our ITE too, with aeronautics, archery, and it's also prohibited out of competition to be used. Billiards, bobsleigh, bowls, bridge, curling, darts, golf, motorcycling, pentathlon, bowling, powerboating, sailing, shooting, skiing, snowboarding, and wrestling. So a lot of these with those finer movements, except when you get to the end of the list, like skiing, snowboarding, and wrestling. Again, also prohibited due to its anti-anxiety effects. Other agents, so creatinine, one thing to remember is that it's actually not prohibited. So there's nitrogenous amino acid compound produced by the liver. Phosphocreatine serves as an energy store for ATP in muscle, first discovered in the 1830s and a supplement that's been used since early 1900s, mainly for short, high-intensity exercise. Potential complications with creatinine are renal dysfunction, liver dysfunction, muscle cramping, and compartment syndrome. So going through some nutritional supplements, supplies one or more nutrients purported to be missing from an athlete's diet. There's unclear benefits and harm to a lot of nutritional supplements. The rationale to use would be to maintain adequate nutritional balance, minimize deterioration of physical and mental performance, improve muscle protein balance, and then reduce possible exercise-related oxidative stress-linked damage, such as the use of antioxidants with vitamin C, E, and beta carotene. So with nutritional supplements, the important thing to remember is that some of these supplements will contain banned substances, and sometimes that's just due to contamination at manufacturing facilities. So like there's multiple bodies that have banned certain nutritional substances, like the NFL has banned companies like General Nutrition Center and MetRx and Metabolife. The NCAA's policy is ignorance is no excuse. What you don't know can hurt your eligibility. Basically saying if you're taking a nutritional supplement and you test positive for a banned substance, that's no excuse and you're still not eligible. Belief in supplements and ergonomic aids as a driving force without real consideration of effectiveness or risks, and then other nutritional supplements such as amino acids or BCAAs. So with drug testing, NFL based in New York, there's a banned substance list and they have a steroid policy, banned substance list, also with NFL Players Association with rules and regulations. NCAA in Indianapolis also has a banned substance list. And then there's a banned substance list with NCAA health and safety and banned drug classes specifically. WADA based in Montreal. In Canada, there's the banned substance list right here. So this is the website that you can go to that has all of the WADA medications that are banned listed. And you can just go in there and search for medication. So if you're not sure, you just type it in. Doping testing with urine, blood, or both. In competition testing begins 12 hours before competition and through the end of the competition. Out of competition, anytime during the out of competition time frame, and this includes all prohibited substances not selectively prohibited during competition. Athletes will be enrolled in the registered testing pool. That's determined by the Sports International Federation or National Anti-Doping Organization, and they're required to report to their location out of competition using the WADA Anti-Doping Administration and Management System, or ADAMS. This allows for relevant anti-doping organizations' drug control officer to locate the athlete for out of competition testing. So control during Olympics. In competition, this begins at 11:59 the day before the competition and through the end of the competition. Out of competition is any time outside of that period. Procedural issues. So there's rights for the athletes associated with drug testing through WADA. So to check the credentials of the doping control officer for any type of control, being notified in writing of a selection process, to be informed about the consequences of refusal to cooperate, and to be informed about the correct sequence of control. Further rights of the athlete. So with the consent of the doping control officer, to always be accompanied by an escort, an athlete is entitled to receive a prize, which I thought was kind of funny and cool. To do a warm down, to receive medical attention if necessary, to attend a press conference, not to stay in the doping station if you have other competitions that day, to select the equipment that will be used, to be observed in passing of the urine by someone of the same gender, and to receive a signed copy of all the documents. Responsibilities of the athlete. are to know the norms of the WADA and other anti-doping agencies, inform the personal physician and pharmacologist that you are an athlete and might be submitting to doping controls, consult to anti-doping agencies like NATO, NOC, or IF with anticipation of a need to use any medical treatments that are related to the banned substance, to complete and submit the therapeutic use exemption forms when required, which I'll kind of go through here in a second, and to keep an actual list of all the medication, supplements, and herbal products that are being used. These are further responsibilities. So careful in ingestion of supplements and herbal products, as they might contain banned substances. Again, always bring an ID with a photo with you to show to a doping control officer in the case of doping control. In competition or out of competition doping control, to remain at all times under the sight of an escort or doping control officer until conclusion. Hydrate and previously closed non-alcoholic beverages. To be prepared to begin doping control process as soon as notified, and be in the doping control collection room until samples closed, and ensure all documentation is correctly made and that you receive a copy of that documentation. So testing procedures. Again, I feel like I'm just kind of reading straight slide for slide off of these here, but these are all kind of important to know. So with the testing procedure, athlete will be notified in writing by the courier. Athlete remains in visual contact with courier and reports within 1 hour. Sealed beverages without caffeine or other banned substances are allowed. Athlete selects a sealed beaker. Specimen is 85 milliliters. If less, then it will be discarded. Specific gravity must be greater than 1.005, and the pH has to be between 4.5 and 7.5. And I'm not even sure why the specimen A, specimen B necessarily is listed here. I think just to show that it has to add up to 85 milliliters. Then the specimen prepared for shipping in the presence of an athlete. Specimen A tested by approved laboratory. Different laboratory personnel testing B sample if necessary. To kind of show that there might be 2 specimens that are collected and can be sent to different laboratories for testing. And then there's similar procedures that are outlined here for blood testing according to the World Anti-Doping Agency. So the therapeutic use exemption, this enables use of a prohibited substance by an athlete. It can be granted if the prohibited substance is required for treatment of an acute or chronic medical condition that would lead to significant impairment to health if the substance were not used. Prohibited substance is unlikely to result in significant improvement in performance. There's no reasonable therapeutic alternative. The condition for which the prohibited substance is being used wasn't caused by prior use of a prohibited substance or method. The TUE application started and became online December 2018. Needs to be submitted 30 days before any competition. And the TUE has a period of validity. After the expiration, a new TUE needs to be submitted and approved to allow continued use of the substance. And then some substances are included in the list of prohibited substances, are frequently used to treat medical conditions found in the athletic population. One that we'd probably see most frequently or more than others would be insulin. And then going through some future trends in doping. So one would be gene manipulation, which would be the non-therapeutic use of cells, genes, or genetic elements or modulation of gene expression having capacity to enhance athletic performance. Has been mentioned since 2000, and then site-specific sequence modification to affect disease versus gain of function expression of exogenous transgenes. So risks associated, so there can be treatment-induced leukemia and death associated with gene manipulation. With animal studies, paroxysmal proliferator activated receptor delta associated with lipid metabolism and expression of slow twitch muscle fibers. Gene transfer vectors such as repoxygen is going to express the EPO gene. Testing, so for gene manipulation, WADA has prohibited gene manipulation since 2004. And basically how they'll use the screening would be to screen for genetic markers that might be used to identify physiological markers. Another future trend potentially would be xenon gas, which is a noble gas and prefers not to react with other elements. It boosts the body's production of HIF1, a protein that may stimulate EPO production. Its official use was sponsored by the Russian government in 2006. I thought that was kind of funny. And then WADA prohibited both in competition and out of competition use in 2012. These are my references, and I appreciate you guys bearing with me. Any questions?
I don't have a
Thanks,
question.
Austin. Can you hear me okay?
Yeah.
Yeah. It's always a dry subject. It's like one of those topics that's like hard not to just kind of read from the slides, because it's packed with info. And I always try and remind people subjects like this are so easily testable because there's not a whole lot of debate. And so, anything that's easily testable is going to be fair game on the CAQ. So it's just one of those topics that you just got to hammer out the memorization for. So super helpful to have the talk at this point of the year.
Sure. Yeah, I definitely at the end, like the screening guidelines and everything, that's all pure memorization. But I know I saw some on the ITE and then definitely some medications that were specific to certain sports too. I remember seeing as well.
So good job, Austin. I have a question that somebody asked me and I didn't know the answer to, and you probably said it, but I missed it. Why are diuretics banned?
They can act as a masking agent because they're increasing the so we're basically oversaturating any potential banned substance, and so they might be screened and be below the limit. And so if they're below that limit because they take a diuretic because there's more water in the urine, that it's
Yeah.
acting as a masking agent. So that's why they're banned.
Huh, interesting.
Yep.
So we talked about this yesterday or whenever I saw you last. The only thing I would say is if you ever have to give this talk to somebody, any of you, like put pictures of people using it in the
Yeah.
sport that they're banned on or something because of like a trigger. You know what I mean?
Yep.
Like, I can't tell you how many times I've listened to this talk in my training, and it's not particularly something I'm interested in. I like literally I should know the diuretic answer. I should, but I just don't listen. So like just to try and keep it fresh somehow. I don't know how to make it more fun, but I don't think there's a way for that. But
I wanted to add some fluff last night. We were driving to Chicago and my computer died on me. I was like, I guess the fluff will get left
are you in
out. But
Chicago?
yeah, I am. Yep.
Oh,
Had to come out
okay.
for my wife's friend's baby shower and birthday party.
Oh, fun. We'll enjoy
Yeah.
it.
Thanks.
Well, thank you for giving the talk and have a good day if no one else has any questions.
Thanks, Austin.
You got it.
Thanks, Austin. Very reological.
Isn't that funny? I had no idea what that meant.
I love it. Well, thanks for enlightening us.
All right. Thanks, guys.
Bye.
See ya.
Bye.